So Kermit and Swapnil, our hosts, you want to take it away?
Yes. So hello, everyone, and welcome to this webinar. Thank you so much for taking the time to join us from all over the world, as we see. And like I said earlier, I think this is a very powerful testament to the fact that this is a universal problem, and it's a problem that people are struggling with everywhere. One of the things that's really key to handling it is coming together, talking about it, and creating supportive communities like this one. So I'd like to say a few words about one of the organizations that's supporting this webinar. That's the International Institute for Psychiatric Drug Withdrawal, or the IIPDW. So we're an organization that's dedicated to supporting every person's right to an informed choice with regard to psychiatric drugs. And we provide a forum for psychiatric survivors, consumers, providers of mental health, to come together and share their practice-based knowledge. And IIPDW associates have conducted, as well as published, a lot of groundbreaking research in the safe tapering around antidepressants, as well as around antipsychotic drugs. They have really lobbied for the inclusion of safe tapering practices and standard guidelines. We are a UK registered charity, and our website is iipdw.org. So please consider supporting our work by connecting with us on social media, visiting the website, and please consider a donation on the website.
I'd also like to welcome you all. My name is Kermit Cole. I was the founding editor of Mad in America, and still on the board there and participate in things like this. And also currently chairman of the board of Open Excellence, which provided funding for the film we're going to see. And this town hall series is well, Mad in America was created in the first place to provide a forum for people who have been affected by these issues, a place to examine the research that exists and also what is not known, and to gather the knowledge and experience of people who have expertise by experience. And so this town hall series is, more in the interest of gathering that knowledge. I think that it's fair to say that in the time that Mad in America has been in existence, we have seen a change. We have seen a much more positive acceptance of people, getting off these drugs, and a reappraisal of how that came to be in the first place, and all of these things. And so that's a positive thing, is that we are creating that community and we are gathering that knowledge. And we're here today to pursue that together. So.
And I'll also add, I'll put a plug in for MIA. If you'd like to donate to MIA as well, Lucy's dropping a link there.
So a little bit about the video that we're all going to watch together today. As the indiscriminate prescription of antidepressants is increasing, we find more and more people who are faced with this really difficult and isolating challenge of trying to go off these medications when they're ready. Now, both the people who are taking these drugs and the physicians who are prescribing these drugs are unaware of how difficult it can be to taper them, and often underestimate of how sometimes agonizing the experience can be. So hence this video. This video offers some very practical guidelines on how to taper antidepressants, and emphasizes that an individualized approach is important. This video was created by Mark Horowitz and Stevie. It was funded by Open Excellence, produced by Mindwake. An important thing to note is that the video has been translated into 4 languages. If you'd like to request an additional one, please tell us in the chat or send us an email at info@iipdw.org. Please feel free to disseminate the video with anyone who you think could use it. Like I mentioned earlier, it's really important to create a supportive community, and the community is crucial in managing this problem.
Introductions now, Sonia?
Yes. Would you like to go, Kermit? Just so people have a break from my voice.
Well, let's and I'd like to invite you to introduce yourselves so the audience can get to know you personally. Let's start with Laura.
Thanks, Kermit. Hi, everyone. I'm Laura Delano. I live in the Hartford, Connecticut area. I'm here today through both my personal experiences of taking many psychiatric drugs, including always at least one antidepressant between the ages of 14 and 27. I came off of them all in 2010, so 12 years ago now. And through that experience of coming off without any information about how to do so safely, I came to the work of helping other people not make the same mistakes I made. I founded a nonprofit called Inner Compass Initiative, based in the US, but we serve people around the world. And our mission is to help people make more informed choices about taking and coming off psychiatric drugs. And we have an extensive array of free information on the drugs themselves and on how to taper off of them. We have a step-by-step tapering manual. We have over 70 live stream videos in our Inner Compass Conversations community on Facebook. We've just launched a new community on Mighty Networks called Inner Compass Exchange, where people are supporting each other, sharing experiences. I'm very passionate about reclaiming the right to have all the information we need to make true choice, because choice is impossible if it's not informed, and none of us to date have really been able to exercise that right. So I'm excited to be here, to see the video, to hear from all of you in the comments. And yeah, find us at Inner Compass Initiative. It's theinnercompass.org. And then the withdrawal project, our withdrawal initiative, is withdrawal.theinnercompass.org. Thanks.
Thank you, Laura. Mark?
Sure. So hi, everyone. My name is Mark. I'm an academic trainee psychiatrist, and I came to this because of my own trouble coming off several psychiatric drugs. I'm still in the process of doing that. I started on 5 drugs and I'm down to 2. I've been tapering for the last few years. I learned early on that the leaders in my field that I worked with had very little useful to say about how to come off psychiatric drugs. And so I ended up learning how to come off my drugs through peer support websites, one run by Adele Framer, Surviving Antidepressants, so I can see is in the audience, and also Laura's website. And for the last few years, I've been working to try to, I guess, educate doctors on how to take people off more safely. And I've written a few papers about it, and I've helped with some guidelines in England. All of my papers are on my website, markhorowitz.org. And over the last year or so, I've also helped to set up a digital clinic now open in Canada, and it'll be open in America next year, called Outro Health, which Adele Frame is also involved in to help people come off antidepressants safely whose doctors are not sure how to do it. And I'm part of the IIPDW and very happy to be part of today's talk.
Thank you, Mark. Stevie Lewis.
Hello. Yeah, my name's Stevie Lewis. I'm a board member of the IIPDW, and you are going to see quite a bit of me over the next 55 minutes when we show the video. So I won't spend too much time here because you're going to get a snapshot of my experience in the film. But I guess the question that we put to ourselves as to what to say here today was what brought us to be on this panel today. And when I thought about that, the answer for me is anger. And I hope that any of you out there with lived experience of psychiatric medication will understand that and resonate with that experience. Anger that I feel that ignorance and misinformation has actually damaged my health, potentially permanently. Anger, when I look back that I was told I had a chemical imbalance in my brain, how frightening that was. I've been told there's something wrong with your heart. Actually now it just rolls off the tongue, doesn't it? It's a phrase that has become so accepted in society, but to me it was shocking when I first heard it. Anger when I found I couldn't get off this drug, that I was addicted to it, which is how it felt at the time. I thought I could do anything I put my mind to, and I couldn't get off this drug without becoming so ill I didn't know what to do with myself. And anger that withdrawal wasn't even recognised as something, and no help. So that's what's brought me here today. I'm very proud to have made the film alongside Mark Horowitz.
Thank you, Stevie. And if I may, I'd like to respond to what you just said. I think that one of the really important things we can help to create here is the knowledge that whatever's happened in the past and whatever you're able to do or not do with the drugs in the future, to me, what's the most important thing that comes out of all this is that people know that they're not broken, that they're not aberrant, that they're not monsters, that they're not something other than fully human. And we can gather our knowledge to do what we can about getting off the meds, but in my experience, this is the most important thing, that people do not, continue to think that they're somehow defective.
Indeed.
And I want to add, and I'll go just quickly, that I wanted to say too, that we are presenting expertise on this panel, but what we found in these series is that what's just as important is everything that happens in the chat, and all the experience that's gathered and the connections that are made and the conversation that occurs there. That the conversation that we have in the panel, we're presenting certain what the people on the panel have learned and what they have to offer. But this is all just to create a dialogue, and that we're creating that forum in the chat where people can gather and know that they're not alone. So that said, let's hear from Anders Sorensen.
Yeah, can you hear me? Let's go through. Perfect. Well, hi everyone, I'm Anders Sorensen from Denmark. I'm a clinical psychologist, and my way into this field was that I early realized how medication could actually interfere with the psychotherapy I was trying to do. It was really difficult to work with people's emotions and dark thoughts if they're numbed. And so I started helping people come off their psychiatric drugs and realized that this was way more difficult than what we just taught at university. So my clients were clearly suffering way worse withdrawal symptoms than what I was just taught at university. And I decided to trust them rather than the books. And that was really how I got into this field. And I recently did my PhD on psychiatric drug withdrawal. And here I am, primarily doing work in my own private practice here in Denmark, helping people come off drugs and doing some research too. So that was my way into it. And I'm very happy to be here.
Very happy to have you. Thank you, Anders. I think now Lucy.
Yeah, I just wanted to say hello. I'm Lucy. I work for IIPDW. So if you have ever emailed us, I'm probably the one who's replied to you. I have my own experience of psychiatric drug withdrawal. I took my last fraction of a pill 6 years ago and 5 days and counting. And I also wanted to say a practical thing, which is in this webinar, we can't give medical advice. So we can't respond to individual people's questions about their tapering journeys. But if you do ask a question that's related to your own experience, we can try and speak to the theme of your question. So it's still, obviously still bring your experiences to the conversation.
Guess I'm left. The last one, yes, okay. So I'm Karina Ruggiero. I'm in San Francisco area, the Bay Area. I'm a business operations professional, and I started working with MIA recently because of my own experience. I was medicated at 13 years old with an SSRI, and I spent 22 years on various SRIs, the last one being Zoloft. And I experienced so I've been off about 2 years now. I experienced a severe and protracted withdrawal, and I had to figure out like what the heck was going on and rely heavily on self-trust through this process. And through that process, I found Mad in America, I found Laura, I found Intercompass Initiative, I found all these amazing people who had walked the path before me. And I guess the main thing I feel called to say is that withdrawal is hell on earth. It's horrific. It's one of the worst things a human could experience in a lot of cases. And I just want to tell you, it feels like when you're in it, I know it felt hopeless, dark, just horrible. But like on the other side, it's so beautiful. Like it's so much more beautiful than it ever was on the drugs. And it's full of light, and life just gets so much better. So I want to say that. And now I'm going to go into a couple of housekeeping items. So the structure of the webinar, it's overall 2 hours. And we're going to go into the screening of the video. There's going to be a short discussion and then Q&A. So we have the chat box and the Q&A box. So the chat box is really just interact as much as you can. As Kermit said, it's just as important as the discussion that we're having here. And another way to interact is that you have this little box at the bottom of your screen that says reactions. You can click on like hearts, smiley faces, sad faces, thumbs up, thumbs down, and the panelists will see it and everybody will see it. The Q&A, so don't put your questions in the chat box, put them in the Q&A. Make sure to put them in the Q&A so that we see them. The Q&A will be public, so everybody will be able to see the questions, but if you want to ask an anonymous question, you can tick a little box, you'll see it, that says send privately. You can also upvote other people's questions. So there's a little thumbs up by the questions that you can view. You can click that thumbs up if it's a question you like that you want to get answered. Like we won't be able to answer all of them, but we're going to pull like the most general themes from them. You can also comment on people's questions. Also, you won't be able to save the chat because we really want to keep this like a safe space where people feel like they can share and be open. So you won't be able to save the chat, but what we're going to do is pull out links and resources, and we'll send those afterward along with the recording. Lastly, closed captions. If you want to view closed captions, there is a live, if you want to turn them off or on, there's a live transcript button at the bottom of your screen, and you can click that and you can turn them off or on, and you can also save them. So I think that's it. Did I miss anything, Lucy?
No, you've
okay.
Yeah, no, you've said everything.
Okay, good. Yeah, so I think we're ready to roll with the video.
Okay.
training video is presented by the International Institute for Psychiatric Drug Withdrawal. The Institute supports the human right to informed choice with regard to psychiatric drugs. Our goals include the development of research and practice-based knowledge that will facilitate safe reduction and withdrawal from psychiatric drugs. In line with that, the subject of the video you're watching is how to withdraw safely from antidepressants. My name is Stevie Lewis. I'm a campaigner who for the past 3 years has been bringing to the attention of the public, UK governments and the NHS the potential for patients to become physically dependent on SSRI antidepressants. And importantly, how to recognise and support people in antidepressant withdrawal. Our aim for today is to explain to doctors and members of the public how withdrawal presents itself and how to help people withdraw safely so they don't have to go through the unpleasant and protracted withdrawal process that I had to. To set the scene for this, I'm going to give you some background on my own experience, and then I'm going to be talking to an expert in antidepressant withdrawal and safe tapering, Dr. Mark Horowitz. We're planning to cover the process of how to identify withdrawal, how to safely taper, and how to stop antidepressants, which we hope will be educational for doctors and members of the public alike. Mark Horowitz is a clinical research fellow in psychiatry at UCL and the NHS. He has a PhD in the neurobiology of antidepressants from the Institute of Psychiatry at King's College London. He has published papers on safe tapering in the Lancet Psychiatry and authored the Royal College of Psychiatry guidance on stopping antidepressants. Hello and welcome, Mark.
Hi, Stevie. I'm very happy to be here.
Let's start by giving some background on my experience with antidepressants. I took an SSRI, Seroxat or paroxetine, which is its generic name, for 17 years. And I didn't choose to take it for that long. I took it willingly for about 3 years in all, and the rest I spent trying to stop. I went to the doctor originally with intermittent insomnia, which happened when I went away on business. And it had happened to me once in the past when I first went to university. And I remembered that the very occasional Mogadon, which is a benzodiazepine, had solved the problem nicely. So that's what I went along for. My GP at the time asked me some additional questions. I told him about the unexplained levels of low anxiety I had once a month. And he then shocked me, really, by telling me that I was on the edge of a clinical depression, that I had a chemical balance in my brain, and that my brain wasn't producing enough serotonin, and that I needed to take this antidepressant, Seroxat, brand name, as I mentioned, for paroxetine in the United Kingdom. I needed to take a tablet daily to correct this imbalance. Now, I already knew about the potential for addiction with the benzodiazepines. That class of drugs includes Valium or Xanax, Ativan. And I asked him at the time if this could happen with Seroxat, and he assured me this was a new class of drugs and that I couldn't become addicted to it. And looking back, the word withdrawal didn't feature in that or any subsequent dialogues with him. So I took Seroxat for about 6 months, and then I decided to stop because I felt fine, and I had about 3 weeks of dizziness and nausea. And it was bad enough that I went to see the doctor with the problem, and he suggested I had labyrinthitis. I then had about a 9-month break during which I didn't take anything, but I had some difficult life events. My mother died, I had 3 miscarriages, and so I ended up with similar symptoms of anxiety and insomnia. And I went back to the doctor, and these symptoms were again attributed to my chemical imbalance. So back on Seroxat for about a year, and I stopped again because I felt perfectly well. And this time I noticed within about 36 to 48 hours, I was feeling quite anxious. I couldn't sleep, I had no appetite, and I couldn't stop crying. The doctor this time said that I had relapsed My original symptoms were worse. I had a general anxiety disorder, and this was a diagnosis I just couldn't argue with because I'd never experienced symptoms like this ever in my life before. So back on Seroxat for another just under 2 years, I think. And I stopped again. I wanted to see if my brain chemicals were now balanced, but I found again the symptoms were even worse. And I noticed that there seemed to be a pattern to my symptoms arriving and their resolution. They seemed to be predictable. There seemed to be a time element to this. 36 to 48 hours after stopping the drug, I became more ill than I could ever remember being. And after about the same period of time, when I reintroduced the drug, I felt perfectly well again. And this made me wonder, is this really me? Am I really this ill? Or possibly, is it the drug? And this prompted me to look on the internet. This was a time when there were only really 2 SSRIs being prescribed. So Seroxat, paroxetine, or Prozac. It didn't take much searching to find that there were a couple of main groups of people out there, one in the US and one in this country, who were all struggling to come off Seroxat, or Paxil, as it's called in the US. And they had exactly the same symptoms as me. And they were claiming that they were addicted to, or as we now know more accurately, physically dependent on this drug, and that the symptoms I was experiencing were the same as they were describing, and they were calling it pure withdrawal. And I learned around the same time that this diagnosis of chemical imbalance that I'd been given had no basis in science whatsoever. So this left me with future years of continually trying to withdraw, and with virtually no support, as withdrawal was not really acknowledged as existing. I had moved to Wales, so I had a new GP, and she did her best to help me. When I asked for help, she supplied me with liquid so that I could reduce more slowly. She helped me with supplying syringes. But it's fair to say that no matter what I did, how many attempts I made, each time the withdrawal symptoms got worse and worse, and they got worse the lower that I went on the dose. This was what I experienced. And as I mentioned at the beginning of this film, our intention is that it helps to educate doctors and inform members of the public so that people in a similar position to me won't struggle and suffer like I had to, because I didn't know what to do properly to taper, and the information available to help me was either limited or inaccurate. Mark is now going to take us through how the science that is available to us now can explain and demonstrate my experience. So Mark, tell us, when I was seeing my doctor, what would they have been told at that time about antidepressant withdrawal?
Right. So first, Stevie, I'm so sorry to hear what you've been through. Sadly, it's an all too common story, and I think it's very representative of what was happening years ago, and probably to some degree is still happening today. And so the first thing is many GPs at that time and still today have been taught to call the symptoms that occur when you stop an antidepressant discontinuation symptoms, not withdrawal symptoms. And this was an attempt by drug companies to try to distinguish their drugs from drugs you've mentioned, the benzodiazepines, that had been associated with withdrawal symptoms. They didn't want their market to be affected in the same way as it had been for benzodiazepines by this negative association with withdrawal symptoms. And so they invented a euphemism, discontinuation symptoms, which sounds much more benign and less threatening than withdrawal symptoms. The description that GPs were taught was that these discontinuation symptoms were mild and they were brief or self-limiting, often for a week or two. And that was what was in the NICE guidelines, the authoritative guidelines in England and in guidelines around the world, including in America. And really the origin of this description was a consensus panel put together by a drug company in which the phrase brief and mild was repeated, distributed in numerous academic papers until it became almost a pharmaceutical meme, a line that was repeated again and again in papers, and that found its way out into authoritative guidance. So when you went to see your GP, they would have expected mild and brief symptoms coming off an antidepressant, not the kind of disastrous, severe symptoms that you presented with.
So what did doctors then know about how to stop an antidepressant?
Along with the idea that discontinuation symptoms were mild and brief, in order to avoid them, not a lot of effort was needed. And so the advice given was people can stop antidepressants over 2 or 4 weeks. And in the NICE guidance for years, it's said that patients can stop their antidepressants over 4 weeks. The advice to stop over 4 weeks was a consensus position of a few doctors at the time and not based on any evidence. And unfortunately, this advice has been propagated through medical school, through lectures, through the GP learning system, and that's what is accepted as the basic practice at the moment.
So can you describe to us then what are the withdrawal symptoms that one gets from an antidepressant?
The withdrawal symptoms you can get from either coming down on an antidepressant or stopping it are myriad. They can manifest in both physical and psychological symptoms, and that's because the neurotransmitters affected by antidepressants, serotonin and other neurotransmitters, affect many different bodily systems, and therefore they have very wide-ranging effects. So, for example, there are physical symptoms like dizziness, headache, nausea, vivid dreams. There are quite distinctive sensory symptoms. People describe electric shocks in their head or even in their limbs sometimes. There are effects on the gut, like nausea, vomiting, diarrhea. There are a number of effects on muscles, so people can get tremors, troubles with coordination, muscle pain, and spasms. One particularly concerning effect of antidepressant withdrawal is akathisia, better known as an adverse effect of antipsychotics, but it can occur in people coming off antidepressants. I've seen it, and it can be horrible. It's described by people as their nervous system being on fire. It can lead people to feel incredibly uncomfortable in their own skin, leading to pacing, and in some cases to suicide because the sensation is so unbearable. So this is probably the worst possible consequence of withdrawal. It's also been found in quite large studies that there is an increase in suicide attempts in the weeks after stopping an antidepressant. So the effect of withdrawal can be very profound on a person, manifesting, yes, as I've said, both in physical and psychological symptoms. In fact, there are lists that list 80 or more possible symptoms. So really, almost every system in the body can be affected by withdrawal.
So why do people get withdrawal symptoms?
Right. So antidepressants work by modifying the levels of chemicals in our brain. So many of them act on serotonin, some act on noradrenaline, others act on dopamine. We now know that there's no evidence for lowered levels of these neurotransmitters in people with anxiety or depression. So these antidepressants are therefore causing a change in the normal chemistry of the brain. And the brain adapts to the presence of these drugs to these changes because of a principle known as homeostasis. So when we're in a cold environment, our body warms up to maintain our temperature. The same kind of homeostatic principle is applied to a neurotransmitter like serotonin. So when it's increased, the brain and the body becomes less sensitive to serotonin, leading to a downregulation of serotonin receptors. And that means that when the antidepressant is reduced in dose or taken away, that the level of chemicals that the brain has become used to is now lowered, and the brain experiences this as a deficit of serotonin. And this is what causes withdrawal symptoms. And withdrawal symptoms probably last as long as it takes the brain to go back to its normal level of sensitivity. So its level of sensitivity before the antidepressant was started. This also helps to explain why withdrawal symptoms can last so long. People often say, well, the drug is out of the body, so how could you possibly have withdrawal symptoms? Yeah. And this is a misunderstanding of what's causing withdrawal. Withdrawal is caused by a difference between what the brain expects in terms of levels of neurochemicals and what's actually provided. And it's the time taken for the brain to get used to the lower levels that explains why withdrawal symptoms can last so long. And if your system takes months or years to get back to normal, then that's the period of time that someone will experience withdrawal symptoms. And now that we understand that, it makes a lot more sense why people can have such long-lasting symptoms. And then it also helps to explain why there's so many myriad varied symptoms of withdrawal. We have serotonin receptors in the gut, for example, and that's why people will have gastrointestinal symptoms. We have serotonin receptors all throughout the nervous system, muscles, and so all of these systems can be affected by withdrawal.
Yeah, you can see, can't you, how what you're describing there is such a chaotic range of symptoms, which I experienced firsthand, and how these must baffle GPs. I mean, for example, I visited my GP for problems with palpitations, insomnia. I saw specialists for gut problems. I developed a movement disorder, and what you're describing there is all these can be traced back to how serotonin affects the body and mind. And you can also tell that doctors think that they are being presented with mental health symptoms, as opposed to what is really happening, physical reactions to the absence of the drug. And this is so important for doctors to understand. This is a physical problem. And I wish my GP had known that. And it's good to hear that hopefully things are changing now, and this aspect of withdrawal is going to be recognised.
So exactly, I think GPs are baffled by these presentations because there is such a wide range of symptoms, and they're also very taught to be very closely vigilant of a relapse. So they're always thinking in their mind, is this person relapsing with anxiety and depression? And that causes them to focus on the psychological manifestations of withdrawal rather than the physical symptoms. I think that leads to a lot of the trouble that we'll hopefully talk about.
Well, yes. So can withdrawal symptoms be mistaken by a prescriber for a return of the underlying condition?
So I think the answer is absolutely, and I think it happens very common. Of the tens of thousands of people on peer-led websites who are getting advice on how to come off antidepressants safely, most of them say that they're there because they had withdrawal symptoms that were misdiagnosed as a return of their condition by their GP or psychiatrist. So it must be a widespread phenomenon. And it's very easy to understand why that might be, because we know that withdrawal symptoms include anxiety, depressed mood, and poor sleep, which can look a lot like a return of the underlying condition. We know that these mood symptoms can be withdrawal symptoms because even people with no underlying mental health condition experience these symptoms when they reduce or stop an antidepressant. So, for example, people who are prescribed an antidepressant for pain or the menopause, when they reduce their antidepressant, they can experience these symptoms. So it's not just people that have an underlying condition. And that's how we can be sure that these are withdrawal symptoms. It's very easy for GPs to make the mistake of thinking this is the underlying condition coming back, because a patient walks in, the first thing they say is they're anxious, they can't sleep, and GPs have been taught, one, that discontinuation symptoms are generally mild and brief. So when someone comes into their office saying, I've got these very severe symptoms, they've been here for weeks, the first thing they're going to think about is relapse, because that doesn't match their description in their minds of discontinuation symptoms being mild and brief. It's also especially likely to occur if the GP doesn't think or know to ask about other symptoms, especially physical symptoms that make withdrawal symptoms more distinctive. So I think foremost in a GP's mind is relapse. You've got to be a pretty clued up GP to ask about attendant withdrawal symptoms like dizziness or nausea or muscle problems, something that will help you distinguish it from an underlying condition coming back. I think that's why it happens so commonly that these withdrawal symptoms are mistaken for a return of an underlying condition.
Then this is really, really important for people, anybody who is watching us now, Mark. How can withdrawal symptoms be distinguished from relapse?
I think there are a few clues that can help both patients and doctors distinguish withdrawal symptoms from relapse, some of which we've touched on. So one is quicker onset for withdrawal symptoms. So people experience withdrawal symptoms often days after reducing or stopping their medication. In some of the shorter acting drugs like paroxetine, it can actually happen within hours of missing a dose. That is not typical for a return of an underlying condition, which can take weeks or months after stopping a medication. There's a bit of a proviso to this in that long-acting drugs like fluoxetine or Prozac can have withdrawal symptoms that are themselves delayed by days or weeks. And sometimes you hear of patients that do experience withdrawal symptoms even in shorter acting drugs that are delayed longer. So I think people need to have a high index of suspicion for withdrawal symptoms, but one clue is happening soon after reducing dose. Probably the most helpful aspect to look for is symptoms other than psychological symptoms that are present along with them. So if someone comes in with anxiety and trouble sleeping, it's worth asking about other symptoms like dizziness, like nausea, like electric shock sensations that are clearly not symptoms of an underlying anxious or depressive disorder and help to distinguish it as a withdrawal syndrome. I think it's also worth saying that if a person has psychological symptoms that are very different from their underlying condition, that's another clue that's probably withdrawal. So if someone went on a medication because they had low mood and they were sleeping all the time, and now, a few days after stopping their medication, they can't sleep and are having panic attacks, completely different symptoms from their underlying condition, it's much more likely that they've developed withdrawal symptoms rather than happening to coincidentally develop a new mental health condition just at the moment they've stopped a medication. Possible, but very unlikely, much more plausible that they've got symptoms related to the change in the drug. So I think it's good for doctors to understand what were the original symptoms and use that to distinguish them from whatever is happening when people come in with new symptoms after stopping their drug. Another way to help distinguish, more helpful in retrospect, I think you've gone through something similar, that when you restart the drug, the symptoms go away reasonably quickly if you restart it soon after the symptoms come on. So if you've been off the drug for a couple of weeks, you go back on it, often people will experience an improvement in their symptoms over a few days. It's a little bit less likely to have as quick an effect if you wait months afterwards, but even then it can improve symptoms. And that is a sign probably that it's withdrawal symptoms if they resolve fairly quickly after restarting a medication. Another thing for people who are making small reductions, they can often see a wave pattern of withdrawal symptoms. Symptoms come on a few days after stopping, they get worse, they reach a peak, they start to improve, and they resolve. And that pattern of worsening and getting better is very typical of withdrawal and different from return of an underlying condition, which can stick around for a lot longer. I think the last thing to say is what is not useful, and that is, I think, a historical idea that if someone has symptoms that are very severe or that are lasting a long time, then that must be a return of their underlying condition. Now that we understand that withdrawal symptoms can be severe and can be long-lasting, that is no longer a very helpful characteristic to help distinguish withdrawal from relapse.
That leads us on really very neatly to our next question. What has happened recently with our understanding of how hard it is to stop antidepressants?
Right. So there has been really a burgeoning interest in this topic over the last few years, and we've learned a lot of things about it. I mean, in reality, the first cases of people having trouble stopping antidepressants because of withdrawal symptoms were first reported in the early 1990s. So it's really been known now for 30 years. But the first systematic review of this topic was only done a couple of years ago by Davies and Reed. And what this review looked at was all the existing studies about withdrawal symptoms, and its findings were quite startling to the field. And what they showed essentially was withdrawal is more common, more severe, and more long-lasting than official guidance had said up until that point. They found that withdrawal symptoms occur in about half of people, no matter what sort of study you're looking at, and that in maybe up to a half of patients to experience withdrawal, these symptoms are severe, and they often last longer than a week or two, with groups of some patients experiencing symptoms that go for months or even years. These findings were reflected in a report put out by Public Health England, the major public health body, finding very, very similar findings. This also led to wider spread recognition by the Royal College of Psychiatrists in England, and also NICE, the producer of guidelines for doctors in England, who both updated their guidance to recognise, first of all, that withdrawal symptoms is the scientifically correct term for what was previously called discontinuation symptoms, which is a helpful step to help understand what is going on, and also that people can experience withdrawal symptoms that are both severe and long-lasting. To its credit, the Royal College of Psychiatrists put out a position statement that advises doctors that they should be informing patients of the possibility of both severe and long-lasting withdrawal symptoms when they stop an antidepressant at the time they're considering starting it. So this should be part of informed consent, that a patient may decide they want to use an antidepressant, but they should be aware of the difficulty that some people have when they're trying to stop it. And so I think there is much more widespread recognition of the trouble people have when stopping these drugs now.
The Davies-Reed research was a game changer, really. I mean, when I think back, I always had the impression that my doctor thought that I was an anomaly. I remember specifically her saying to me, I've lots of people on Seroxat and they're fine. And she seemed mystified by what was happening to me. And I guess that she and most other prescribers just don't see withdrawal because they're not expecting to. And through Davies and Reed, we now know that it is actually more likely than not that you will have some form of withdrawal.
Yes, I think that's exactly right. I think what was one of the most startling findings was how common withdrawal is. And I think you've said it probably correctly about GPs. It's very hard to see something that you haven't been trained to see. And so I think a lot of GPs are seeing a lot of relapse or a lot of return of people with underlying condition because they've been trained to see that rather than to see withdrawal.
Yeah. So where are we now with the understanding of how to stop antidepressants?
So along with the interest in withdrawal, there's also been increasing interest in what is the safest way to stop antidepressants. And I think over the last few years, we've developed a slightly more sophisticated understanding of how to stop antidepressants safely. And this has been based on some studies that have been conducted, a better understanding of the pharmacology, the way these drugs work, but mostly a lot of clinical experience, especially a lot of patient-led experience from the sort of peer support groups that you received advice from that have now proliferated around the internet, with people like Adele Framer at Surviving Antidepressants really contributing to greater understanding of how to come off these drugs more safely. I think it's very well summarized in the guidance put forward by the Royal College of Psychiatry on how to come off antidepressants. And they make some general comments to start with. So this is guidance that was published at the end of 2020. And they recommend, first of all, that patients who have been on antidepressants for more than a few weeks taper off over months or longer, meaning that some people will take years. They suggest going down to very small doses for some patients, perhaps less than 1 milligram before stopping. And they recommend going down in smaller and smaller size reductions as you get to lower doses. And they also advise that people should go down at a rate that the patient can tolerate, and so that the rate should be titrated to what the person can handle. And a little bit of work that we did helped to explain where this guidance came from, that helped to inform the Royal College of Psychiatry guidelines. So a couple of years ago, we looked at the way that antidepressants act on the brain. And this is a graph of a common antidepressant, citalopram, the way it affects the brain, in this case showing its effect on the serotonin transporter, the major target of these drugs in the brain. And what you can see is the relationship between dose of an antidepressant on the bottom axis and the effect on the brain is not a straight line, but it's this curve, what the shape we call a hyperbola. And that tells us something about what happens when you reduce your dose. So a lot of doctors intuitively think that going down by even amounts of dose makes sense. So for example, if someone's on 20 milligrams of citalopram, it seems perfectly reasonable to go down to 15, 10, 5, and then 0 milligrams. But what you can see from this graph is the first reduction from 20 milligrams to 15 milligrams causes this very small decrease in effect on the brain. The reduction from 15 to 10 causes a slightly larger decrease in effect. Going from 10 to 5 will cause a slightly larger effect on the brain, but going down from 5 to 0 will cause this incredibly large change in effect on the brain. And this very much matches what patients report, that as they get down to lower doses, actually, as Stevie mentioned, the withdrawal symptoms get worse. And it's probably because there's larger changes happening to the equilibrium of the brain. These bigger changes are causing bigger disruptions. And so from this, we guess that it makes more sense to reduce antidepressants in such a way that it reduces the effect on the brain by even amounts rather than even amounts of dose. And so to produce even amounts of reduction of effect on the brain, in this case, 20 percentage points, requires this rather peculiar pattern of dose reduction, a hyperbolic pattern of dose reduction, because it matches the curve, where each reduction becomes smaller and smaller. So at first you can reduce by 10 or 15 milligrams, then the next step, reducing by 2.5 milligrams, then by 1.5 milligrams. And the final dose before completely stopping is a very small dose, in this case, 0.8 milligrams, so that the reduction in effect on the brain is not much larger than the effect of those previous dose reductions. And it's from that the guidance on how to come off antidepressants safely has been derived. And that's why the guidance recommends going down by smaller and smaller amounts, down to very low doses before stopping. And in particular, you can approximate these sort of reductions by making proportional dose reductions, which means, for example, reducing dose by 10% or 20% of the most recent dose you've been on each month. So for example, if you're making reductions of 10% a month, the reductions will become smaller and smaller because the total dose you're on gets smaller and smaller. And this guidance is now not just in the Royal College of Psychiatry guidance, but also in NICE guidance that advises all doctors in England. There's also a little bit of evidence that slower tapering is more likely to produce better outcomes. So in a paper that we reviewed, done in Japan, it shows that people who come off antidepressants over 9 months have a lot less trouble with withdrawal than people who come off very quickly. And in fact, in that study, people came off over lengths of time between 1 month and 4 years. And in that way, most of them were able to avoid withdrawal symptoms. So we're understanding that the slower that you go, the less likely you are to have unpleasant withdrawal symptoms. And there's also been some studies using tapering strips, which are small doses of antidepressants that allow you to make this kind of hyperbolic dose reductions. And in a number of studies put out about tapering strips, it's shown that people that were not able to come off their antidepressants by coming down more quickly were able to come off them when they used these smaller doses and went down to very small final doses before stopping. And we now know that some people may take years to come off their drug safely. And this is simply because this is the time it takes for these people's brains to readjust themselves to lower levels of the drug. I might give a couple of examples because that makes it a little bit easier to make sense of what's happening. Here is an example given in the Royal College of Psychiatry guidance that I would consider a fairly rapid reduction. And this is an example of citalopram, and it's suggesting reductions made by 50% every 2 to 4 weeks. So someone who's starting on 40 milligrams of citalopram would halve their dose to 20. If there was no significant symptoms or no very unpleasant withdrawal symptoms, they would then go to 10 milligrams after 2 or 4 weeks, and then halve again. And to achieve this kind of small dose, they would need to split a tablet in half. If withdrawal symptoms were tolerable, they would go for another step down to 2.5 milligrams. By the time you're down to these sort of small doses, tablets will not be small enough to be able to make up these small doses. And so you can either use liquids, which are available in many countries, or other options like tapering strips or compounding pharmacies, which make up small doses. Keep on halving the dose until you got down to that very small dose, so that this final reduction to 0 won't cause a bigger change in effect on the brain as these previous steps. And if things went well with no withdrawal symptoms, you would then stop the medication. Of course, if things didn't go so well, if you had significant withdrawal symptoms, then you want to slow down this reduction and introduce intermediate steps. So you would make, rather than 50% reductions, you might make 25% dose reductions. And if that caused too many withdrawal symptoms, you would go down even slower, down to 10% every 2 to 4 weeks. And if that caused too significant withdrawal symptoms, you go down even slower. An example of an even slower reduction for a drug that's particularly hard to come off, paroxetine, which Stevie knows all too well, is also given as an example in the Royal College of Psychiatry guidance. So this gives an example of reducing by 10% of the most recent dose every 2 to 4 weeks. So in this case, starting on 40 milligrams of paroxetine, the first reduction you'd make is 10% of 40 milligrams, which is 4 milligrams, down to 36 milligrams. Straight away here, there's going to be difficulty making up this exact dose using widely available tablets, which generally come as 10, 20, or 40 milligrams. And so you're going to need to either make up the entire dose with a liquid preparation, which is generally widely available, or a combination of tablets and liquids. Further dose reductions would then be made by reducing by 10% of that dose. So 10% of 36 milligrams is 3.6 milligrams. So now you're down to 32.4, then 10% of that dose. And you can start to see that because these doses are not similar to those easily available as tablets, people will need to be either using liquids, compounding chemists, or tapering strips in order to make these small reductions. You can see the dose gets smaller and smaller, and as you get down to lower doses, the size of the reductions becomes smaller and smaller. And in fact, this is an abbreviated version of it. In this little box here, there are almost 30 further steps as you go down very slowly, 10% a month, down to this very small final dose before stopping. And again, going down to this small dose of this final step down doesn't cause more disruption than the doses beforehand. And so because each of these steps might take a month, going through this process can take several years. And I've certainly seen people who have taken 3, 4, 5 or longer years to come off paroxetine, which is particularly known for its severe withdrawal effects. In fact, it's worth saying some people can't come off even this quickly and will need to come off at half this rate or less. And so some people will have severe withdrawal effects from minor reductions, and we'll need to find a rate slow enough for them to be able to tolerate it. That's a very worthwhile guidance to look at.
What you've been through, Mark, there is, well, it's a brilliant example of the science explaining my experience of trying and so frequently failing to withdraw. Everyone believes that the lower you go, the easier it will be. And intuitively, you can see why. But you've shown that the absolute opposite is true. It sounds like 5 milligrams is a really small dose and that you should be able to stop with no problems. But in actual fact, that really is not the case. And how I got into a cycle of getting down around that, having terrible problems and thinking I've just not done it slowly enough, and going back up. And this became an unpleasant cycle over many years.
Another thing to mention is that although all effort should be made to make the process as tolerable as possible for the patient in all the ways just described, going slowly, titrating the reduction rate to the pace that a patient can tolerate, it is still likely the process will not be without some bumps, at least for some patients. And so for this reason, it's also very helpful to have support and understanding throughout the process from people around them. For some people, the support might be from a professional counsellor, ideally one that is well aware of withdrawal, but for everybody it helps to have family and friends informed about the process, especially because some people will be used to seeing symptoms as a reason to go back on medication. And so educating family and friends about the process of slowly stopping, about withdrawal symptoms, can help to put everybody on the same page so everyone's heading in the same direction. This also applies to other nurses, doctors involved in the person's medical care, because there is such a poor understanding of withdrawal from antidepressants generally. It can lead to all sorts of misinterpretations from people around them. So it's good to keep all relevant medical staff informed. And because it can be a difficult time for people, having support, having understanding from people around them can make a big difference. There's also a range of coping skills that might be useful for someone going through unpleasant withdrawal symptoms, including distraction, mindfulness, light exercise, amongst others, very much depending on what people are used to using to get through difficult times. One thing that can be very helpful is simply to remind people that what they're experiencing is likely to be withdrawal symptoms, that they're transitory, that they will resolve. People can lose perspective sometimes when in the midst of withdrawal symptoms. And there are lots of good resources around for further coping techniques in places like the Withdrawal Project online, and the guidance for psychological therapists also available online, put together by different psychotherapy organizations led by Anne Guy. And another thing that might be useful is for people to plan early on to have their professional and social duties arranged as much as possible around withdrawal, to the extent that that is able to be achieved. So
are there any other tips or tricks that you can give to people to help them avoid the difficulties I had?
Right, so I think you made probably the main point there, which is counterintuitively, as you get to lower doses, you need to slow down your tapering because of the effects of very small doses, which lots of people have learnt the hard way, and we now understand what the neuroscience is underlying that. I think another common error that people make is they work out that going down too quickly causes severe withdrawal effects. And so they think that they will slow the process down by taking drugs every second day or every third day, which makes, again, intuitive sense. You're thinking you're taking less of the drug. But the problem with most antidepressants is they have a half-life of about 1 day. A half-life is the time taken for the body to excrete half the drug. And so if a drug has a half-life of 24 hours, that means your body will get rid of it, will get rid of half of it every 24 hours. If you take such a drug every second day, your blood levels will go down to a quarter of what they normally are. after 1 day, it's down to a half. After 2 days, it's down to a quarter. After 3 days, it's down to 1/8. And that very large decrease in the levels in your body can cause severe withdrawal effects. So I think a lot of GPs with well-meaning intentions give the advice to take drugs every second or third day in order to get down to lower doses. I think that advice often backfires and causes severe withdrawal symptoms. And it's better to take a smaller dose each day. And that necessitates using something like a liquid version of a drug or making up smaller tablets with a compounding pharmacy or with tapering strips. And I think even though that's more trouble, it's much better for the patient. And I think that's worth saying that for safe tapering of most people, they can't do it with currently available tablets because the doses are simply too large. And most people will need access to some form of the drug that allows smaller doses. And that means GPs prescribing things like liquids or other smaller tablet forms. I think another point to make is people assume that it's very easy to come off fluoxetine, which has a longer half-life than other drugs. It might be easier, but fluoxetine can be a tricky drug because withdrawal symptoms are delayed after reducing or stopping the drug, and that can make it harder for people to spot. Drugs with a short half-life of paroxetine are very easy to spot because people feel terrible a day or two afterwards. Whereas if it's 6 or 8 weeks down the track, people often don't put it together in their head. So I don't think fluoxetine has been thought of as being self-tapering because it goes down of your body over a few weeks. But because we know that some people will take months or years to come off these drugs safely, it's not self-tapering enough to just stop it abruptly. And it should also be tapered in much the same way as other drugs. And I think the last point to make is the process of switching from one antidepressant to another is not as simple as it's sometimes presented, because you are in effect withdrawing from one drug in order to get onto the other drug. And so you have the issues with the adverse or side effects of the new drug, but you also have the problem of withdrawing from the first drug. So I think the process of switching is much more complicated than people often think it is.
In my own research and based on the many people in the same situation as me that I've spoken to, what's going to be so vital about all of this is patients actually being believed when they go into their doctors, and a discussion can be had about the fact that they could really be in withdrawal, that this range of symptoms is withdrawal, that doctors will acknowledge that they will believe it, and therefore their families and friends will believe in it too, because it is such a wide range of symptoms. And you touched upon earlier how important it is that there is this new narrative. We're looking for a new narrative in the doctor's surgery, that at the time of first prescribing, that there is a genuine informed consent, so that a fully informed patient is made aware right at the start of the risks and benefits of taking these drugs, which of course could lead people to actually decide that they might not start on the path of taking an antidepressant, that they might try exercise, social prescribing, even the good old wait and see approach, because we've learned that sadness can pass, feelings of sadness, these feelings of emotional distress will pass with time. So, you know, looking back, I wonder if I'd known all of this, whether I would have taken an antidepressant in the first place. But to wrap up, what would you tell a doctor or a patient now? What are the take-home messages so that a person doesn't end up like I did, stuck on an antidepressant for years and struggling with appalling withdrawal?
The main take-home messages are, 1, we shouldn't mistake withdrawal for relapse. So feeling anxious or depressed when reducing or stopping antidepressants is not necessarily a sign of relapse. These symptoms are very common in withdrawal, and we should bear that in mind. Tapering antidepressants over much longer periods than we're used to tapering them over, for example, months or sometimes years, for people that are on long-term medications is more likely to be successful than quicker tapering. Number 3, when we make reductions, it should be by smaller and smaller amounts. As the total dose gets lower,
called proportionate or hyperbolic tapering because of the way drugs act on the brain. Number 4, some patients will need to go down to very small doses before stopping, for example, a fraction of a milligram for some patients with some antidepressants. Number 5, in order to make the small reductions of antidepressant needed, patients will need access to either liquid versions of the drug or another way to make up small doses, for example, tapering strips. Number 6, very importantly, the rate of tapering should be modified or titrated based on the patient's ability to tolerate the reductions, particularly regarding withdrawal symptoms. And they should be able to go at their own pace. Number 7, with the exception of fluoxetine, the short half-life of most antidepressants means that every other day dosing risks withdrawal symptoms, and it's better to take the same small dose every day. Number 8, there is increasing sources of good guidance, for example, from the Royal College of Psychiatrists, now from NICE. There's guidance in the Maudsley prescribing guidelines, and the IIPDW website is full of useful sources of information. And number 9, although a gradual individualized taper is the best way to minimize distress caused by stopping antidepressants, the people certainly benefit from the support and understanding of their loved ones around them and from well-informed professionals.
Thank you very much, Mark. You've been through a lot of information there, which I think is going to be really valuable. And that detailed explanation of how the science demonstrates what patients experience is vital to help make sense of what can seem like this wide range of chaotic symptoms, which are in truth a physical response to the absence of the drug, not a growing or enduring mental health problem. And just as you did there, I'm going to re-emphasize that although the science may be constant, human beings are individual and unique, and each person will have a different response to an antidepressant and to its reduction. And it's vital that everyone is enabled and free to go at their own pace. So we hope that this information that we've passed on today has been helpful in providing more of an insight into the difficulties that some people may have when coming off antidepressants, and how to be able to recognize those difficulties when you might not have seen them in the past, and how to support other people through this process. So this film was made on behalf of the International Institute for Psychiatric Drug Withdrawal. We are a not-for-profit organization. We rely on your donations to help us keep our organization going, including our website. So if you found this video useful, please consider supporting our work. We are at iipdw.org. And by donating, you'll be helping to add to the growing call for an informed global response to the issues of psychiatric drug withdrawal. Thank you and goodbye.
Mark and Stevie, thank you so much for sharing your experience, sharing your knowledge. As we'll see from the Q&A and from the webinar chat, there was a great need for this information. From my own experience working with people who have taken these drugs, I think apart from the practical guidance that you offer in the videos, one of the biggest benefits is how validating people found it, and realizing that they're not crazy just because there's no framework in medicine to understand these symptoms. That doesn't mean that the symptoms don't exist. So I think that really takes a big weight off of many patients and helps them. So at this point, I would like to invite Laura and Anders to weigh in.
Anders, you want to go first?
Yes, of course. Yes. really, this is absolutely crucial information to successfully coming off antidepressants. It's needed. It's no doubt that most of the failed withdrawal attempts I've seen and heard about and can see out there in the community are caused by making too large dose reductions simply, and by stopping the dose at a dose, the drug at a dose corresponding to a very high biological effect. And that's the whole point of this, right? Which appears very small in terms of milligram. That's why people have been maybe thinking that they're crazy all these years, but actually this data turns out to prove that you were right, guys, because it's actually a very high dose. So what doctors call a small, sometimes here referred to as a placebo dose, small dose. You could just stop that. And it's really extreme how small dose reductions the body can sometimes detect and make withdrawal symptoms from. Now, I've reviewed all the data and I see this every day, and it still continues to surprise me how small reduction. So we just look at this data. If you ever feel in doubt, there is a difference. And that combined with the general understatement and misconception of how long-lasting and severe withdrawal symptoms can actually be, often mimicking relapse. And there we have the problem, which so many people face. I've had people succeeding in coming off antidepressants, not all of them, but there's definitely a population just by getting this information and nothing else of how slow to actually taper. People who previously suffered very severe withdrawal symptoms and considered themselves, well, whatever psychiatry would call it, like recurrent, chronic, treatment-resistant depression, that we could actually help just by this information. Because technically the solution is obvious. It's hyperbolic tapering and enough time, really. And then strategies to help people get through periods of distress, horror, sometimes hopelessness, which to me is fundamentally a question of really being in pain without analyzing or acting on it. And I think we have some very valuable psychological methods. That's where I come from, to help people get through that and detach from that distress without following it, without acting on it. So to me, the implication from this research, occupancy research, is very positive, because it means that more people can come off their drug than we thought, because of the risk of people having deteriorated because of withdrawal symptoms from the linear tapering in the guidelines is just too high. So to me, below all this is a very, very, very positive story for many people. I've seen that.
I second Anders' response. Bravo, Stevie and Mark. It's such an important contribution, especially to professionals who, really so few mental health professionals out there have any awareness that this even exists. And yeah, I think you touched on so many important topics and questions. You covered so much, right down to, not skipping days, just really good practical information. The things I would add, because there's so much, you have so much richness in there. And I think in part, I'm guessing that there were certain topics that maybe couldn't be addressed because this might be geared for mental health professionals, or because you're a professional, Mark, coming from the purely ex-patient side, one of the things that's so important to help people remember is that that a lot of the withdrawal journey is really about calling into question this belief that we need doctors to do this, that we need to turn to experts who have letters after their names to help us successfully get off these drugs. There are some individual doctors out there who are informed about what it truly means to safely taper, but I think I would just offer from the kind of more like outside the system perspective that we have so much power just within us as ordinary people who are not professionals to teach ourselves about safe tapering, whether it's at Surviving Antidepressants that Adele has created and led for so many years, through Intercompass Initiative and the Withdrawal Project with our manual and our communities. We have all the information we need to do it safely ourselves. And I know in my experience, having been such a deeply invested good patient for so many years, including my childhood years, and that is a whole different conversation. What does it mean for a child to choose to take a drug? Can they even choose in the first place? But I know during my decade and a half of being this good patient, I completely let go of any sense of trust in myself, any sense of faith in my own capacity to figure things out on my own. I just deferred to professionals all the time. And as Anders was just getting at, and which is so, so important, I, of course, was taught to be afraid of my pain and discomfort, especially my emotional pain and my thoughts and my mind. Of course, as Stevie said it when she shared about her own personal experiences, when you think your brain is defective, you're of course not going to trust in yourself, because the very seat of your consciousness is supposedly broken. And so I think in the withdrawal journey, I think whether you're a professional working with someone who's coming off, or you're coming off yourself, or you're a family member of someone coming off, there's so much important work to do around the beliefs we have about our pain and about our relationship to our minds. And I think getting all the technical information about how to do this safely is so essential. It's so essential. But really, that's the beginning of the journey, because then it's about learning how to be with yourself and your mind and your pain without being afraid. And that it comes especially handy in the withdrawal journey if you do end up having difficulties, which I should say, as the video said, not all people have a hard time getting off these drugs, especially if done really, really, really slowly. And so it isn't inevitable that you'll go through hell. Let me see. Yeah, I think that whole, the last thing I wanted to add to that, I'm guessing this was strategic as well when Mark, you were talking about if like how to help someone figure out if it's withdrawal symptoms or underlying condition relapse. I know, I'm guessing I'm sharing this with like-minded people here, but in my experience, having taken these drugs for 14 years of my life, when I was coming off them, there was no distinction between, it was impossible to distinguish between just me versus the effects of the meds. I mean, these drugs had shaped every facet of my physical being through the most formative years of my life. And so coming off of them, any time I wondered, is this just who I am? Is this my baseline? Is this some, new problem? I had to keep going and hang in there with the uncertainty until enough years passed and I healed enough to see that every single facet of my emotional, physical, spiritual, sexual, creative, interpersonal being had been impacted. And I really needed years and years and years still to this day, I've been off for 12 years and I still sometimes I'm not sure if I don't still have some kind of relationship to those meds just because I was on them so young. So I would just say to anyone who's struggling with, could this just be me? I just putting that question to the aside entirely for a while because it's so impossible. It's so impossible to answer that accurately. I'll stop here, but I just want to congratulate you again on this. It's going to help so many people. It's so informative. Amazing job.
I'd like to just say that I was very touched and moved, Laura, when you mentioned the loss of your authority over your own experience. I think that's just so key to all of this, is the message that people are given that their thoughts, their feelings are irrelevant to the process, and that whatever help we can bring to people to, take ownership of their own experience. That's key. Thank you. I think we'd like to make space for some of the questions that are coming out. There's been just a lot of great questions. I know, Laura, you've been very actively responding. Are there any one of those questions that you'd like to put to the panel?
You're asking me? Yeah,
I'm asking you.
I mean, there's so many questions, but one that really struck me as so important. Let me see if I can find it. Came towards the beginning. This person shared anonymously, I don't intend to taper, and I tried to taper before with medical supervision. It didn't work. But I still want to come to these webinar events because it expresses my freedom to choose and the importance of my informed consent. Liberation. Can you speak to the role this webinar plays for those now decided on staying on the medication? Because I think it does play a role. I would never have attended these things even 10 years ago out of fear. It's such an important question. I can let someone else speak, but after others speak, I'd love to respond to.
That's a very interesting question, isn't it? And I guess we all kind of have a presupposition that people want to stop taking the drugs, and that's why one would taper. I went through a patch in my life when I thought I would be on them for the rest of my life because I couldn't get off, because I would go down to the magic 5 milligrams and fail because of the belief that I had that it was a very low dose and it wasn't doing anything for me at that point. So yeah, I stuck with I'm probably going to take this the rest of my life now. The most important thing I think is that one chooses what's right for you. And so when I made that choice, I felt that it was the only thing that I could do to maintain a reasonable life for myself. Because on the very small dose, what I thought was a very small dose of the drug, which actually was in liquid 1.78 mil, I can be absolutely precise, and I'd added water to that, which was 1.7, so that's 3.4 something milligrams of paroxetine, Seroxat, Paxil. That still was a big dose, apparently, once you understand hyperbolic tapering. I know that now, I didn't know it then. I was taking what I thought was a very small dose, and that was what I was going to have to do to keep withdrawal at bay. And that was exactly the right decision to make for me at the time. And if that is the decision that someone else is going to make, to stick with it, to take the drug, because that is the best life that they can give for themselves, then that is absolutely the right thing to do. And that personal choice is what we are talking about here. Informed consent, it then gives you the personal choice as to whether you're going to take a medication or not, and also as to whether you decide to stay with it or not. It's entirely a matter for you. You know your body, no one else. Nobody with a PhD or any professorship or any sort of letters that they've got after their name. You know your body, you know what's best for you. I will just throw in something changed for me, which is why I went, no, I've got to get off this stuff. And that's because I mentioned during the video, I developed a movement disorder, and I hoped that if I stopped taking the drug, that the movement disorder would stop, because it was terrifying, deeply unpleasant. And I still have it to a much lesser degree, and it's still not very nice. So I stopped at 3 point whatever I said, at the 1.78, and I had 4 years of very unpleasant withdrawal. But I had a motivation. I had the push that maybe my body wouldn't keep moving involuntarily. That's what got me through. That's one of the things that got me through. But if you decide to stay with them, entirely the right thing to do if that's what feels right for you.
Does anyone else want to respond? Or should I do? I'll jump in. Yeah, I think I thanks for sharing that, Stevie. I think that was a really is your personal experience grappling with that decision was helpful for me to hear too. I think this movement, whatever we want to call it, that we're all a part of, can become so polarizing, or it can be perceived to be polarizing when perhaps it isn't as polarizing as it might seem. And of course, our broader world has become so polarized that I think it can feel very black and white, very, good and bad, right and wrong, especially in the context of these drugs. And I know myself early on, when I was first waking up to all of this and to the fact that I'd lost like the most formative years of my life to these diagnoses and these drugs, I was so angry. I was so against the whole thing. If you had anything to do with the mental health system, if you took meds, you were wrong. And I think I needed to go through that, and I needed to swing to this end of the spectrum for a while to kind of find my footing and help, and so that I could root myself in my own healing and my own voice and my own sense of self, like separate from it all. And I eventually came to see just how much bigger, and Swapnil, you speak so beautifully about this often as well. Just, this is such a complicated, it's so much more than just taking or not taking a psychiatric drug. It's about the life you're living, the upbringing you've had, your socioeconomic class, rate. There's so many broader factors that play a role in whether the decision to come off of these drugs is right for someone or not. And speaking as someone who was born into a family of financial means, so I never had to go into the public system. I never had to go on disability. When I was in withdrawal, my parents were paying my rent. I couldn't work, and it was still, with all of that support, it was the hardest thing I ever did in my life for years. And I think it can be really easy when you intellectually grasp the problems of these drugs and how we've all been betrayed by the DSM, the diagnostic model, and the corruption within the whole industry. It's so easy to just think it's as simple as like, everyone just needs to get off of them. And it really isn't. And I don't think our movement makes enough space for the complexities of life, of being alive, of needing support, having or not having access to resources. And I think we all need to have this conversation more, because it's a big decision to whether or not to come off. And some people truly feel helped by these drugs, and in knowing what they are and what they aren't. And who are any of us to say, to deny that experience? So I'm so appreciative of this person asking that question.
Lucy and Karina, I believe that there were some questions that you found particularly striking and you'd like to bring up to the panelists from the Q&A box.
Yes, there was a question that caught my eye. I can't actually find it in the Q&A anymore, but I wrote it down. And I wanted to raise it to the panel because in the video, Stevie talks a lot about her conversations with her GP and struggling to be believed or properly supported. And I also had that experience, and I'm sure lots of people in the audience. So the question is it sufficient to have a support group during withdrawal, or is medical supervision necessary? And also, is it possible, is it practical? Sort of, I guess, answer the ideal scenario, but also the reality as it is now.
Well, I can always answer a question or always say something which may or may not be relevant. I think it's already been mentioned somewhere in the panel that there are so many resources out there now. There have been so many people left to deal with this outside the medical profession for so long that there is a good hard kernel of information available to you. We would all like to believe that your doctor will hold your hand during this. But what I see is that, certainly experience here in the UK, I can't speak for other countries, but there is no way that a general practitioner can take the time to spend to go through with people what is required in order to help them go through this process in the sort of detail that's required. So my feeling is that family support and peer support and learning about what to do yourself is going to have to be the way forward. It's not ideal. We want there to be NHS services. This is the one area of my campaigning which doesn't seem to have got very far. I was always campaigning for recognition of withdrawal, and I think we've made great strides with that. But help and support for people who are struggling with withdrawal, that is still absent. And so whether we like it or not, doing it yourself, putting a team together of friends, family, joining local peer support groups, whatever is possible, you can do this yourself. Not ideal, but we do not live in an ideal world.
I get this question a lot because I'm doing this work as a clinical psychologist and not a psychiatrist, and I've been pondering this a while. I haven't found, as weird as it may sound, any bit of information or knowledge that a general practitioner psychiatrist has that we need in terms of this. The knowledge is in the layperson community, and we've confirmed it with some data from research, but I firmly believe that we don't really, there's no knowledge. We could need a supportive person if the doctor is that. But most of the times, sadly, with the people I see, the doctor becomes, which is really unfortunate, like a what is that called? He's resisting the project. He she inserts doubt, makes people doubt even more whether it's withdrawal or relapse. So, and stuff like that. So it can definitely be destructive. But while that, I think it's still important that we do not make this us against them. I think we need to, as we talked about earlier today, educate our doctors. So every time a doctor sees a person going through psychiatric drug withdrawal in this way and it succeeds, we're kind of adding to this whole mission we have, right? So I think it is important to keep them on for them to see how it actually goes with hyperbolic tapering. So it's a balance between those two in my mind.
Yeah, so maybe I'll jump in there with I guess I've got a slightly mixed perspective. I mean, first of all, I should say, unless you're compelled by a community treatment order to take medication that your doctor orders, you can do whatever you like with your medication. It's your medication. You can cut it up. You can dissolve it in water. There's no law against that. You're not bound by some copyright by the drug company, so you can do whatever you like with your medication. I get people asking me this by email. You know, what am I allowed to do things that my psychiatrist says that I shouldn't do? The legal position is, you know, a psychiatrist is an advisor to you. They're not, unless you're compelled by a legal order. So that's the sort of legal bottom line. I think life is probably easier if there's someone who's writing a prescription for you that you can access and oversee things. It does take away different barriers for you, so that's probably helpful. I think Anders' point is important, but it may not be selfishly important. But you know, there's 250 million people on these drugs. I think that a lot of people aspire to change or abolish the psychiatric system. It's very unlikely to happen soon. If doctors are not a part of the solution, it'll be much harder. So, you know, England is clearly a very different place to America on this matter. But at the moment, because I've seen some questions from people in England asking about where can I find a doctor to help me do this? Technically speaking, the national guidelines say that the doctor should be doing what I outlined in my lecture. The NICE guidelines talk about proportional reductions of medication. In the depression guideline, it explicitly says you should use liquid formulations if it's not possible to make up small doses with tablets or capsules. It implies that for a variety of other psychiatric drugs in the guidelines. So technically speaking, if a doctor is not doing that, then they're acting against the standard advice and they open themselves up to legal challenge. So things have changed greatly in the last few months in England because the standards have changed. There's a lot of time taken from guidelines changing and practice changing on the ground, but you know, people should be able to come in with the guideline printed out, available online for free on NICE's website, and doctors respond to NICE guidelines because that is what dictates what is best practice. And there's been specific political circumstances in England that's made that possible. That's possibly not, it doesn't exist in America. But I think, given that so many people are dependent on their doctor's advice, that it is useful to do what Anders has suggested, to inform the doctor, let them know what's going on. So, it seems incredibly unfair to talk to people that are harmed by medication and ask them to educate their doctors. It's, completely the wrong way. But if you don't do that, no one will ever learn, no one will be aware of the problem. We've just done a very big survey of people that are on Facebook groups. And a lot of them, obviously go to Facebook groups because they're getting better advice than from their doctors. But because doctors are not, being told what's going on, not being potentially complained about, there's some sort of feedback that gets to them, they're left in the dark. Possibly that's because they want to be left in the dark. But, if you make it impossible for that to happen, I think that will create much, much bigger change more quickly, as has happened in England. So that's my sort of mixed, somewhat contradictory thoughts on that point.
Could I just add, when I'm consulting with people who are struggling with talking about this with their prescriber, I've found it can be really helpful to, if you want to come off these drugs, you want your prescriber to support you in it. Thinking at the emotional level, and whenever you're deciding how to bring this up with them, putting yourself in their shoes where they're immediately thinking liability, going outside the prescribing guide, the standard of care, all of that. So couching anything you're sharing in that in that way, anticipating that that's the first thing they're going to be thinking about. So a lot of times, we'll help each other. I'll help someone put together a proposed taper plan. And that includes, like, this is what my support looks like. This is what my plans are if things start to go south. Kind of do all the legwork up front, showing that you've thought this through carefully, that you understand all the possible risks. And then you kind of people will present that to their prescriber, and their prescriber's almost kind of like, oh, phew. Okay. And so that can be a really useful way to kind of get the prescriber on board, but from a place of authorities. So you're stepping into the driver's seat. You're the one who's basically saying, like, this is how I would like it to go. And yeah, just another plug for the importance of grassroots mutual aid. That's why Intercompass Initiative exists, so that we can all support each other in this as we figure out how to talk to our doctors or not talk to our doctors and do it covertly and all of that. So come find us at Intercompass Exchange if you're looking for that support.
Thanks, Laura. I'd like to mention that Stuart Shipko, who's a psychiatrist that, as I mentioned earlier, wrote one of the early books on this topic, commented in response to the question about support. He said, a psychiatrist cannot do anything to ensure safe tapering that a good support group can't do. That's coming from a good source. And he also, yeah, and he also adds that there's actually a danger in working with a psychiatrist. And again, he is one. He says, if there are problems with tapering, the psychiatrist invokes bipolar. So hazards all around. I'd like to bring up, because it was a question in the Q&A, and it's really important. Do you all have observations about post-SSRI sexual dysfunction? Should I take that as a no?
I mean, I have comments, but I feel like I'm speaking too much.
Well, I invite you to step in.
Okay. I mean, I think it's a really serious and unexplored issue that I don't know the percentage of people who have this experience. And I feel incredibly lucky because I had zero sexual function. I had my first orgasm when I was 27 years old after coming off. So, and I I regained my function, really lucky that it came back pretty quickly. So it goes deep to my heart. I know there's a new, maybe someone else, it's not fresh on the top of my head. I've seen a new initiative out there on Twitter that's spreading awareness about PSSD, if that's the right acronym. You know, I would like to be hopeful that, you know, this idea that for some people it's permanent, do we know that for sure? Maybe it's just really delayed. I mean, it's definitely an under-researched, unresearched topic. I know people who had it, who didn't have it for like years, and it's slowly coming back. It hurts to even think about the ramifications of this, because to me, this goes to the heart of what it means to be human, one's sexuality, and the betrayal, especially young people who never got to have a sexual life. I don't know if anyone in the comments here is a part of that new initiative, or anyone here has been following it on Twitter, but it seems like they're trying to really draw awareness to this and create more public education resources on it, because it's a profoundly important issue. And I want to stay hopeful that people can regain function. It just maybe takes a lot of time for some. I don't know what others think about it.
I do know that maybe the initiative you're talking about, Laura, is the RISK organization. That is the group of people with David Healy, Professor David Healy. They put together a prize, raised money for a prize to offer to any researcher or scientist who could come up with any clue or any answer to help with this particular problem. I'm not aware that anybody has yet, so it's clearly looked upon as being a very difficult and complex issue. I know that David Healy looks at it from the point of view that it could be that if someone could come up with this one thing, it may give an indication as to a whole load of other difficulties and problems that people encounter with protracted withdrawal. So there are people trying to solve the problem, just not there yet.
And just to quickly say, I found the Twitter handle for the group I was thinking of is PSSD Network, and it's at PSSD Network on Twitter. That's I think they're new too, so they'll be a great addition to RX Risk.
Yeah, the numbers of people will be growing. The voices will get louder.
Thanks. There's a really interesting question I'd like to invite comment. Why are doctors not measuring serotonin, GABA, and dopamine levels?
That's one for Mark.
I'll answer that one. Science question. Essentially because they can't. I mean, in short, you know, you can measure these levels in your blood, you can measure it in urine, you can put a needle into people's spinal cords to get the fluid around the brain. There are no known differences between depressed people and healthy controls, which is why it's not you know, when you go in for a broken leg or an infection, they do all these tests because there are known differences between people with an infection, without an infection. They don't know anything like that about any mental health condition. You know, all of these, you know, people have often heard about chemical imbalance reasons for mental health conditions. They're all hypotheses. They're often based on that a condition is caused by the opposite of the effect that a drug has that people have thought helpful for it. So the idea that depression is low came from early findings that drugs that pepped people up and made them feel better would tend to increase serotonin. And they thought that, well, maybe depression is caused by reduced serotonin, and similar findings in things like schizophrenia. Drugs that block dopamine seem to improve people's symptoms. They thought that maybe schizophrenia is caused by an increase in dopamine. But there's very mixed evidence for all these theories in different studies. I've just worked on a paper that looked at the role of serotonin in depression. and really studies that find that it's increased in some people with depression, some the same, some decreased. It's very, very mixed, and overall, there's really no evidence of any difference between people that are depressed and people with what they call healthy controls. And so, that's why it's not part of the workup, the investigations that people do in hospital. A lot of this has also come from amplification by drug companies. They've taken hypotheses that were academic and they've spread this idea around because it obviously facilitates the sale of medications. Because if you believe that you've got a chemical problem, then a chemical solution makes a lot of sense. So they don't measure it because there's nothing clear to find. It's not even easy to measure. I mean, the idea of what is a chemical balance is itself a very fraught idea. The chemistry, in our brain is constantly changing. It changes when we see things, when we think things. So, the idea that there's some kind of definitive balance is a slightly ridiculous idea to start with. Kermit, I think you're muted.
Would anybody else like to weigh in, or do we consider that covered? Well, we're almost out of time. And I guess I'd like to invite Swapnil. Do you have any reflections on what you've heard today?
I think the feeling that's uppermost for me is I'm glad that we are talking about it. I'm glad that people are available to support each other. And that there is so much that physicians, psychiatrists don't know. And I wish more psychiatrists and physicians would join forums like this, so we could learn from each other.
I think what touches me the most is that that what's being emphasized here is that your experience is your experience. I mean, we can offer research, we can offer our experiences, but what comes out over and over again in these meetings is that people have been told that their experience is somehow not valid and not real, and that's a crime. That psychiatry, and of course, we want to be careful to know that a lot of people who go into psychiatry go in for very good reasons, and there are a lot of very honorable and very good psychiatrists. But the field itself has to taking authority over people's experience and invalidating their own judgment about their lives, and that's horrible. But what also moves me about these meetings is how it underscores that we are not alone. That there is a whole network of people out there that this experience brings us in touch with, and wonderful people that I'm grateful to get to know. So, Stevie, do you have reflections?
I think that the last thing that I would like to say is to everyone out there who is watching this and who is struggling to withdraw from an antidepressant or any of their psychiatric medication, having decided that that is what they want to do, to know that it is possible to come off. The body seems to be a wonderful thing, and it heals. And I think this is when you are in the crisis of withdrawal, when you're feeling at your absolute worst and you just cannot imagine that you're going to get through another 24 hours. It's really, really impossible to have two beliefs. One is belief in yourself, that you can bear what feels utterly unbearable. And the second is that your body's on your side. And as you reduce and take these these drugs out of your system, you will find that your body will start to work again. It may not be as good as it was before, particularly when you're someone further up the age range as I am, but nonetheless, you can withdraw, you can come out the other side, you will heal, and you will have a good life.
Stevie, a lot of people have asked if they can send a film, if they can recommend the film for other people to see.
Absolutely. The more people who see it, the better. And can I repeat what was said earlier? We're slowly adding subtitles in so that the film can be seen in different countries. I understand that there's a whole range of languages that we can subtitle it in. What we need is someone to subsequently go through and check that the language is correct and that it matches and that it makes sense. So anyone prepared to contact the IIPDW with the suggestion of a language and being prepared to back that up, will going through it and checking that it is absolutely correct. We would love to hear from you.
Thanks. And before we go, Karina and Lucy, would you please come back so we can thank you properly?
Go on.
Hi, guys. Do you have any reflections?
I wish I had this. I wish I had this information. I guess I would say I did a taper over 6 months after 22 years, and it was way too fast. If I had it to do over again, I'd do it a lot slower. And I wish I had this video. And my final reflection is I have a belief that everybody heals. And it might take a long time, but I really liked your message, Stevie. You know, it takes time and you cannot see it when you're in it. You can't, but you just got to keep going. You got to keep going. And there's so much for you on the other side. Over to you, Lucy.
Yeah, I just want to echo what Karina and Stevie said. I think I said at the beginning, I'm 6 years and 5 days of psychiatric drugs, but each day it's a slow and hard journey, but each day it does get that little bit easier. And I've seen some of the comments that, you know, that desperate pain that some people are in. So I just feel like we can't really say that enough. You know, it does get easier.
Well, I'll just say it. Thank you, everybody. Thank you, Swapna, Laura, Mark, Stevie, Anders, Lucy, Karina, everybody who attended today. Thank you for bringing all of your experience and all of your love and care. And I'm very grateful to be a part.